Currently used ones are beclomethasone, budesonide, and fluticasone. And systemically, we tend to prefer to give hydrocortisone, which is short-acting in case of acute severe asthma, while we give prednisolone, intermediate-acting in case of chronic severe asthma. Now, this is the mechanism of action. This glucocorticoid, it has got two pathways. One is the simple for rapid non-genomic response, and another is for delayed genomic response. Okay. Now this delayed genomic response is all mediated through the DNA. Fine. And this one is immediate response, which is not mediated through the DNA pathway. So let us see this. In the glucocorticoid pathway, the glucocorticoid enters through the cell membrane of the cell and it attaches to the glucocorticoid receptor. Once it attaches to the receptor, now it gets a privilege to enter into the nuclear membrane. Once it enters into the nuclear membrane, it is going to cause activation of the DNA genes, and then there will be production of mRNA. Once the mRNA is in the picture, it is going to cause production of annexin A1 proteins, which are the proteins produced through the mRNA. Now, when this is produced, it is going to inhibit the COX and that is the cyclooxygenase pathway and the phospholipase A2 pathway, that is phospholipase A2 enzyme. So this is where that final action will take place, but this is going to be after 2 to 3 weeks. Matlab, this is a long term action of the corticosteroid, and actually it is the main action of the corticosteroid. Okay. So you have to remember this. It's important, and corticosteroids are really game changer whenever you are doing a clinical practice. So the mechanism of action we have seen, they have anti-inflammatory effect by inhibition of phospholipase A2, then decreasing prostaglandin, leukotriene, decreasing the inflammatory cells in airway, then stabilizing the mast cells, decreasing the histamine release, decrease capillary permeability and mucosal edema, and inhibition of antigen-antibody reaction, then upregulate the beta-2 receptors, having additive effect to the beta-2 agonist. So multiple ways it is going to work. It is not a single formula or a pathway we can say that it is going to work through this only. It works through multiple ways, and so it is very, very beneficial in a especially compromised patient. And another thing, you will see that it has got anti-inflammatory actions we have seen, then it has got immunosuppressant actions. Metabolic effects of glucocorticoid are hyperglycemia, increased protein catabolism, stimulation of lipolysis, that is fat redistribution. Then mineralocorticoid effects, sodium and fluid retention, and potassium excretion, that is causing hypokalemia, and increased blood volume, that is hypertension. Then behavioral changes, depression, and ultimately there is also long-term bone loss leading to osteoporosis. So you have plus minus both the things with corticosteroids. You have to pick the patient which needs to be given the steroids as per the clinical condition of the patient, so that ultimately you benefit him. And routes of administration, you have the inhalation, then orally and injection. Then corticosteroids in asthma per se, you will have that they are not bronchodilators, they reduce the bronchial inflammation, reduce bronchial hyperreactivity, and have delayed onset. So within 2 to 4 weeks the actual effect comes, and then given as prophylactic medication used alone or in combined with the beta-2 agonist, and in any kind of asthma you can use it. So systemically you want to give steroids. In that case you have to judge and find out that whether it is a case of status asthmaticus or it is an acute asthma exacerbation where you can give in the corticosteroids, and another is severe chronic asthma. So finally, if you classify where we can give, it is the inflammatory disorders, autoimmune disorders, and immunosuppressants. जितने भी आपके ट्रांसप्लांट्स होते हैं, रीनल ट्रांसप्लांट, हार्ट ट्रांसप्लांट, liver transplant, उन सब में corticosteroids they are required essentially, बिना उसके आप transplants नहीं कर सकते. Okay, so corticosteroids are important in higher level of sciences. So the side effects: adrenal suppression, growth retardation in children, and then susceptibility to infection. The moment you suppress the immunity of a person, the body becomes much more prone for infection. Then there is osteoporosis, and then fluid retention, weight gain and hypertension, hyperglycemia, fat distribution, cataract and psychosis. Then inhalation, why we use inhalatory steroids? That because they have got less side effects. And the side effects upon inhalation comes through, they are the oropharyngeal candidiasis, that is the oral thrush which we call. A person who is on long term steroids, inhalational steroids, they tend to develop oral candidiasis, oral fungal infection, because the steroids given inhaled, they move to the oropharynx also. Okay, steroids are not sniffed, वो नाक से नहीं लिए जाते, they are taken through the mouth, that we will see. So when you are taking it, that is inhaling it through the mouth, in that case that is going to cause oral candidiasis. So we have to also remember that whenever you are prescribing steroids to someone and then you need to stop, then you need not to stop it abruptly. जैसे आपने दिया, एक महीने तक स्टीरॉइड दिया, पेशेंट वेल सेटल्ड हो गया, नाउ योर एम इज टू reduce the drug or stop the drug, so you do not stop it abruptly. आप उसको एकदम से बंद नहीं करेंगे कि ओके अब कल से मत लेना. Okay, because when you are giving steroids externally, they are going to suppress the adrenal functions. आपका जो adrenal pathway होता है उसको suppress करता है, तो from inside the body the steroids formation is less and you also remove the support. तो क्या होगा कि there will be different pathophysiology which will start in his body. So what we do is we taper down the steroids level. पहले 8 mg देंगे तो फिर 4 mg करेंगे, 4 mg से 2 mg करेंगे. Like this way we taper down the steroids. We never stop them abruptly. Now these are the GINA guidelines, that is the global initiative for the asthma. So pan world they follow these kind of guidelines for the treatment of patient coming with asthma at different stages and in context of different you can say age. So there may be a child, there may be a male, female, or there may be an elder person coming to us for the management of asthma. And so it has classified like into a mild episode what you need to give, then mild, if it is episodic, then the treatment is step 1. If it is chronic, mild with chronic, that means it is persisting, then you have to go with the step 2. And if it is moderate symptoms, then step 3. Then if it is severe, you have step 4. And then further, if it is severe and still it is persisting, so that is your step 5. Okay. Overall, you will see that these are the short forms: inhaled corticosteroid, oral corticosteroid, SABA. SABA is short-acting beta-2 agonist, and LABA, that is long-acting beta-2 agonist. So SABA, LABA, now these words you will definitely see in the clinical practices. Whenever you have emergency postings, you will hear and also you will use these words, SABA or LABA. Okay. Then you have leukotriene receptor antagonist. So now in this inhaled corticosteroid and formoterol we are giving, or you can remove formoterol and give short-acting beta-2 agonist. Formoterol is long-acting beta-2 agonist. As I told you, it depends upon the clinical condition, whether it is a child, whether what the patient is saying that I need to go back, you treat me as of now. So depending on all those things, you need to give one corticosteroid, another beta-2 agonist. Beta-2 agonist may be short-acting, may be long-acting. Steroids, definitely inhaled ones, and in inhaled ones also, we have to see that they are low dose, low dose, then medium dose, and then high dose. So this basically is giving you a IQ कि हमें इस तरह से स्टेप वाइज ग्रेडेड वे में ट्रीटमेंट करना है. ओके. Then the last resort drug is the omalizumab, that is the anti-IgE monoclonal antibody. As we have seen in the mechanism of action that IgE antibodies were formed, they used to bind with the mast cells, and then when there is an allergen, that used to bind with the IgE antibody, which brings about change in the mast cell and release of histamine and other leukotriene cytokines is there. So what we tend to do is we tend to block the more and more circulating IgE in the blood, and that is done through omalizumab. The worst part of the drug is that it is very expensive. It is not having a good affordability. So it is not practically used, and it is the last resort when you can convince ki okay, now we have nothing further to give. Steroids have also been tried and still the patient is losing his breath, so we can further give a try of omalizumab. So this is a monoclonal antibody directed against human IgE, and it is going to prevent IgE binding with its receptor on the mast cells. Then it decreases the release of allergic mediators. So expensive, so it is not the first line of drug, and always it is given subcutaneously because it itself is a protein, and when you give it orally it becomes ineffective, it gets digested. So this is how it works, but due to its expense we do not use it, and it is the last resort drug. So a short note you always get in this topic of status asthmaticus. So status asthmaticus, that is a refractory asthma which is not coming in our control in spite of giving steroids, in spite of giving different kind of drugs. So that we classify as status asthmaticus. And you have any patient of asthma that has potential to develop acute severe refractory asthma, may be life threatening. So the treatment modality, you give hydrocortisone because it is short acting, and salbutamol plus ipratropium bromide because this combination is synergistically working and is going to cause bronchodilation. And then oxygen inhalation, then salbutamol, terbutaline, these are given IM or subcutaneously. Now the point is, when the person is breathless and we are giving him or her inhalational medicine, so that may be a reason that you give something on inhalation and the drug does not reaches the site of action. Site of action is the bronchioles, the thin bronchioles which are filled with the mucus. Okay, so that is the site of action. But when already person is breathless and we give something to inhale, so the drug may not reach up to the site of action. So therefore we have to give this salbutamol, terbutaline as IM or subcutaneously also. Okay. And then finally, if nothing goes well, there is intubation and mechanical ventilation. So the next topic is COPD, that is chronic obstructive pulmonary disease. Now it is a chronic irreversible disease, and important thing is that smoking is a very, very huge risk factor for COPD. So you can see that this is the normal healthy alveoli. Okay, and here you have a picture of COPD where the walls of the alveoli are destroyed and there is excessive mucus secretion within the bronchioles. So COPD is, we can say that it is totally avoidable if smoking is not done. The treatment you can give antibiotics, then inhaled bronchodilators, inhaled glucocorticoids, oxygen therapy, and if suppose nothing goes, then in the last you have the lung transplant. Then inhaled bronchodilators in COPD, they are the basically antimuscarinics, which are the first drug of choice for COPD, and along with them we can give the beta 2 agonists. Now see, this is a picture of respirometer wherein we are talking of force expiratory volume V1, okay? That is the force expiratory volume of air in first second. So that is, suppose we are talking for 100, starting at the age of 25, moving till age of 80, and here we have two variants. One is a person who has never smoked, A quality profile, okay, first number person, he has never smoked. So you can see that FEV1, that is force expiratory volume in the first second, is quite high whenever he or she reaches 80. Then also it is above 75, okay. So these kind of people, they never face problem, chahe COVID aa jaye, chahe kuch bhi aa jaye, okay, because their lungs are not compromised, they are very strong. Now this is the second category, second profile, which is a highly compromised profile. जब भी सीजन चेंज होगा इन्फेक्शन पकड़ेंगे, जब भी कोविड आएगा तकलीफ पाएंगे. सो हेयर what happens is that in the COPD, in this case you can see that force expiratory volume V1 declines, and it declines very sharply. So by the age of say 45, you tend to get into below 75% of FEV1. FEV1 ये होता है कि आपने एयर इनहेल कर ली, इनहेल करने के बाद आपको कहा कि अब आप बाहर हवा निकालें, तो कितनी फोर्स के साथ आप हवा बाहर निकालते हैं पहले सेकंड में, दैट इज FEV1. एंड देन देयर इज फोर्स्ड वॉल्यूम, दैट इज टोटल वॉल्यूम, यानी कि टोटल आप मान लीजिए 100 सीसी हवा बाहर निकाल रहे हैं, उसमें से फर्स्ट सेकंड में आपने 10 सीसी या 20 सीसी बाहर निकाल दिया. सो दीज आर टू डिफरेंट थिंग्स. एक तो टोटल वॉल्यूम आपने कितनी बाहर निकाली अपॉन एक्सपिरेशन, और दूसरा फर्स्ट सेकंड के अंदर आपने कितना वॉल्यूम को बाहर निकाला. सो इंपॉर्टेंट फॉर अस इज दिस वन फॉर द फर्स्ट सेकंड, बिकॉज ऑन दिस बेसिस ओनली वी क्लासिफाई. सो COPD जो है दैट टेंड्स टू डेवलप, एंड देन दिस इज द बेसिक पिक्चर, ओके. So you have aerosol delivery now, that is how do you give the inhalation. See, you have two type of delivery mechanism. One is the solution form and another is the dry powder form. So in the solution form you have meter dose inhalers and the nebulizers. And in the dry powder form you have spinhaler, rotahalers, okay. So best way in bronchial asthma is to give through aerosol delivery system, and it is highly efficacy and good safety. Then spacer is used. Why we use spacer? It has got its own importance in improving the inhaled to swallowed drug ratio and to reduce the oral candidiasis. Okay. Then 10% of the inhaled drug reaches the site of action, which is very, very poor, but still it is doing its work, and we see patients are relieved of their asthmatic attack. And you have 1 to 5 micrometer diameter particle depositing upon the bronchioles and delivering the drug. अगर इससे छोटे पार्टिकल्स होंगे 1 माइक्रोमीटर से छोटे, तो वो वापस से बाहर आ जाएंगे थ्रू एक्सपिरेशन, और अगर इससे बड़े होंगे तो दे विल नॉट लैंड अप इनटू द ब्रोंक्यूल्स विच इज द साइट ऑफ एक्शन. द बिगर पार्टिकल्स दे रिमेन एट द लेवल ऑफ थ्रोट ओनली, दे डू नॉट गो डाउन, ओके. सो 1 to 5 micrometer diameter particle is actually the size which reaches down into the bronchioles and brings out its effect at the site of inflammation. So you can see that whenever the aerosol is used, say meter dose inhaler, then the drug is moving into the lungs and partly it will move into the GI system like this way. Okay? So these are the different meter dose inhalers. This is a single picture of a meter dose inhaler which is showing different parts. So you have one canister which is containing the drug, another is the plastic accuter, this, and this is the spacer. Okay? And this is the cap. So the utility is, when you are using this, the spacer is placed in between the mouth and the inhaler. Okay? And then there is a rotahaler. Now this capsule, which consists of a dry powder, so whenever you are going to turn, the capsule will break and the dry powder will come into the glass bottle, and then you need to inhale it. And then there is a dry powder inhaler. So this is something which you have to keep in mind, these devices, their functioning, and most important is the role of the steroids. So who will answer the first question? Raise your hand. First question का answer, chromoglycate useful in many patients with asthma because what is the mechanism of action? C, that is the prevents antigen induced degranulation of the mast cells. Then question number second, which of the following drugs does not have a direct bronchodilator effect? Prednisolone, good. And then third, 22-year-old man is brought to the emergency department after suffering seizures resulting from an overdose of a drug that he has been taking, and his friends state that he took the drug orally and sometimes had insomnia after taking it. So which of the following is a direct bronchodilator that is most often used in asthma by the oral route and is capable of causing insomnia and seizures? Theophylline. Okay. So we hope that you will do well in your exams. Okay, on 4th